guest speaker this evening, Dr. Awais Aftab, and all the members who have joined us, Assalamu alaikum. I am Shizat Asham, final year MBBS student from King Edward Medical University, and on behalf of KemPsych, I welcome you all to this talk on the series, Choose Psychiatry. Before I introduce our speaker for today, I would like to request Fiza Zahid from 4th year to kindly give a brief introduction of KemPsych to Dr. Awais Aftab and to our audience. Over to you, Fiza.
So, established in 1860 as Lahore Medical School, King Edward Medical University is the 4th oldest medical institute of South Asia and the oldest of Pakistan. Currently, King Edward Medical University is the one of the top-ranked teaching medical institutes of Pakistan. And KemPsych is the first ever student-based or student-run interest group in King Edward Medical University, which serves to provide research platform and opportunities, and to not only to the students of KE, but also to all of the medical students of Pakistan. The idea came back in September 2020 when a group of students were given an opportunity to join and attend a psychiatric internship program held by the Department of Psychiatry, Mayo Hospital, Lahore. And previously lacking knowledge about this field of medical sciences and realizing that how we are lagging behind the world here, we felt the need of creating such opportunities and programs more often. So the aim of creating a learning community and to inspiring the students to join and contribute to the field of psychiatry led to the development of this interest group, KemPsych. So the talks and lectures by the world-renowned psychiatrists and undertaking research and crash courses about the basic psychiatric themes and public outreach and awareness programs are our main areas of research. KemPsych hopes that through this initiative, will inshallah be able to bridge the academic gap in psychiatry between Pakistan and the rest of the world. And this will facilitate not only the aspiring medical students, but also the future of psychiatry in Pakistan.
Thank you, Fiza. I would not be exaggerating if I say that our today's guest speaker at such a young age has had all those accomplishments to his credit, which take decades and decades for many to accomplish. It is with immense pleasure and honor that I introduce our today's speaker, Dr. Awais Aftab. A graduate of King Edward Medical University, Lahore, Dr. Aftab did his psychiatry residency from Case Western Reserve University in 2018 and Geriatric Fellowship from University of California, San Diego in 2019. He is currently serving as Assistant Professor of Psychiatry at Case Western Reserve University, Cleveland, Ohio, United States of America. His scholarly work has been published in world-renowned journals such as the American Journal of Psychiatry and the Journal of Clinical Psychiatry. He is the producer of and leads the interview series Conversations in Critical Psychiatry for Psychiatric Times, and is also the senior editor for Philosophy, Psychiatry and Psychology, the associate for Current Psychiatry, and triage editor for International Psychogeriatrics. Thank you so much, sir, for taking out time for us today and giving us the honor of hosting you. It is an absolute pleasure to have you with us tonight.
Thank you so much. I'm very glad to be here, and I think it's a great initiative. I think most medical schools here in the U.S. have various sorts of interest groups, and so students start getting exposed to these kinds of activities pretty early on in their medical training. So I'm really heartened to see that students at KE have started this as well, and I do think this would be extremely beneficial. Particularly regarding psychiatry, because I think the exposure to psychiatry is fairly limited during your medical training.
Thank you so much, sir. Your time means a lot to us. So without wasting any time, we'll go ahead. Before talking about the present and future of psychiatry, let's go back a few years. Would you like to take us back to your journey through medical school? What kind of student you were? And as an undergraduate student, how was your relationship with psychiatry back then?
Sure. So this was, I think it's almost 10 years now that I graduated. So I graduated in sort of like early summer, spring of 2011. So it's almost 10 years now to the month. Uh, so I guess sort of like, going back to when I first started at KE. But by the time I started at King Edward, I was already fairly interested in psychiatry at that time, and this is because in my pre-medical years, I had a very strong interest in philosophy and psychology. So I was reading a lot of philosophical literature. I was sort of like reading about some of the early psychological work, especially some of the work related to Freud. And so I knew that I was sort of like, these were the sorts of topics that really interested me. I think sort of like, before medicine, in some ways, my sort of like real passion was philosophy. And I think if circumstances were different, I might have sort of like, gone towards like philosophy as a professional route. But I think as everyone can understand, like that would pretty much be financial suicide in Pakistan. And and there are a lot of physicians in my family, so there was this sort of like tradition and sort of like a path set up uh, that this was something sort of like viable and respectable for me to do. So I ended up in King Edward, and as a sort of like I started getting my medical education and I started learning about different specialties, it became obvious to me very quickly that psychiatry was sort of the only specialty that really interested me, and that it fit my temperament. It sort of like it provided a sort of intellectual sort of like curiosity and stimulation that I needed. Um, so I had that realization even as a first year medical student, and I sort of like so I knew that this was a likely possibility. It was still quite difficult though, because as you know, sort of like psychiatry has a lot of stigma in Pakistan, like both within the medical profession as well as outside in the general society. And there has been this stereotype for a long time that if you sort of like, if you're a good student, if you get a lot of, if you sort of like, if you perform well in exams, then you should go for something like medicine or surgery or some other specialty. And that only those people go into psychiatry who are not able to like perform academically that well. So there's sort of like, there's that stereotype, and then sort of like there's general stigma and misunderstanding and confusion regarding what psychiatric conditions are, what sort of like madness entails, some of the cultural narratives around it. So kind of like, so my family was not very happy with this idea, sort of like, so when they realized that I was interested in psychiatry and that's something I wanted to do, there was a lot of resistance, especially from my parents as well as from my extended family, other physicians in the family. The sort of message that I was getting was that sort of like, why are you going towards psychiatry when you can go for something else? Sort of like, there's almost this sense that, like, are you kind of like wasting your medical career? Are you throwing away all the hard work that you're doing? And it was difficult sort of like to confront that reaction and sort of like and deal with that. And I think I struggled with that for a lot of my sort of like, a lot of the years that I was in KE. And even though I think my interest in psychiatry remained pretty persistent, I think there were times when I kind of wavered under pressure from my family to consider whether I should do something else. I think there were sort of like brief periods of time when I was looking into whether whether neurology could be a viable option. I think there was another point when I was thinking about radiology, but I think it was pretty obvious to me that psychiatry was the really thing that I wanted to do. And I think I also realized that I would not really be happy doing anything else. And and there was also this sort of like, I guess, internal confidence in me that I knew that this was something that I really wanted to do. And I also knew that this was a specialty that is worthy of sort of like, people going into it. And I think that the thing I sort of like, I realized that if people like me don't go into psychiatry, then nothing is going to change. So I also sort of like, I think when I was thinking about, when I was contemplating about this career choice, there was also this, I think, larger moral aspect to it, that I'm not just deciding for myself, but I'm also sort of like deciding for other people around me, as well as people who are going to follow me. And that, you know, in order to change things and in order for us to reform the impression of what this specialty is about and what people can accomplish in this, I need to sort of like go into that and sort of like, you know, do the best I can and show that. So so that's kind of like, you know, so eventually, you know, I did end up going into psychiatry. And I think once I graduated, once I was in US and I was, you know, I started my residency and I was performing well there, I think my parents realized that this was the right decision, and I think that they finally saw that this was, you know, this was something that was the right thing to do. So I think that they have been quite happy with the end result as well. Regarding what sort of a student I was, that's a interesting question. I think so. Before I mean, I fortunately somehow for some reason or another, I've generally been pretty good student academically. This was particularly so before I started KE, sort of like, you know, sort of like I had sort of like, you know, in my session, like merit number one in Punjab at that time. So there was sort of like, you know, so going into KEs, I think there was this sort of like this general, like the question in my mind was that, am I going to sort of like, you know, try to perform and compete at the same academic level or not? And I think there were several sort of like, I was sort of like, I'm struggling with that question for a variety of reasons. One thing is that I think the way the academic systems are set up, I think there is a disconnect between what you need to learn on paper in order to say, you know, score well on an exam versus the sort of meaningful learning that you need to have in order to be a better physician, a better clinician, and generally have a better academic understanding of the subject matter. And also, I think the way medical education is structured in Pakistan, you spend a lot of time studying material that is not going to be of clinical relevance, you know, once you graduate. You know, the amount of emphasis that we have on, I think, a lot of the basic sciences, a lot of emphasis we have on some of the other stuff, it sort of like it doesn't match with the importance of sort of like, you know, of what subjects are the more clinically relevant, what sort of things the rest of the world is focusing on, the sort of stuff that gets, you know, taught in medical schools in the US. So there's that disconnect. So so I sort of like, you know, I decided, you know, when I started at KE that I was going to be sort of like, you know, a good student. I'm gonna try to perform well. I'm gonna sort of like, you know, I'm gonna try not to fail. Unfortunately, I didn't. But I didn't have in mind that I'm gonna obsessively try to gun for the top positions, because that didn't seem to me to be like a worthwhile endeavor. So what I was doing, I think, during my years at med school, was that I think I was trying to provide myself a sort of like all-rounded education that I think I had lacked. So, you know, so I was reading a lot of philosophy, you know, during the med school years. I was reading a lot of literature. I was reading a lot of psychiatry, psychotherapy stuff. I was reading about psychiatry on my own. So I think I was focusing on the sorts of academic and sort of like, you know, philosophical literature that felt important to me for my own intellectual development, at the same time while balancing it with the academic requirements you know, of med school, which, you know, as you all know, are quite substantial. So so I think, you know, in the end, I was able to balance that fairly well. I was also quite active in the blogging circle in those days. So blogs were still a relatively new sort of like, you know, phenomena of sort of like, you know, of internet in Pakistan those days. So I was quite active as a blogger, and I would sort of like, I would blog about philosophy and religion and some of stuff like that. So I was involved with some of the larger discussions that were happening in Pakistan as well. I think overall, I see my time at KE as a very intellectually fertile period, and I'm very glad that I did not devote myself exclusively to the books that, you know, that sort of like are assigned reading for us as you know, as part of medical education, but that I also expanded my horizons, and I studied a lot of the other things that I think in retrospect proved to be very useful.
Right. So it was basically your interest in philosophy and psychology that that ultimately made you pursue psychiatry. And for those participants who don't know this yet, we'll be having a separate talk by Dr. Awais Aftab on the philosophy of psychiatry on 26th of May, inshallah. So to get to know more about it, do join us. But here I would like to ask that what made you so interested in philosophy and psychology? Because usually at our stage, when we enter medical college, students usually even don't know what psychiatry or psychology is. So it was basically your personal interest and your personal study that helped you grasp this knowledge and pursue psychiatry. So what was it exactly that made you so interested in philosophy?
Uh, I don't know if I have a very good answer to that, and I think I think different people are attracted to different sorts of disciplines and different sorts of subjects. I was very curious. I think from quite an early age. I think sort of like I used to read a lot. I used to read a lot of different things, and so for example, I think when I was in sort of like around like in seventh grade, eighth grade, ninth grade, I was very interested in modern physics at that time. So I used to read about astronomy. I studied a lot of astronomy at that time, and from astronomy I started getting interested in modern physics. I was sort of like reading about Einstein's general relativity, special relativity, quantum theory. I read some of the popular stuff by Stephen Hawking. And so as I was sort of like learning about sort of like some of these sort of like theories from modern physics, a lot of sort of like that material was sort of like also dealing with what we sort of like call the larger metaphysical questions. Sort of like like what is the nature of reality? What is the nature of scientific knowledge? Sort of like how do we know what we know? How can we justify sort of like what the scientific theories tell us? And sort of like what is the picture of the world that emerges when we look at these scientific theories. So I was sort of like, that's something. So during my O-levels years, I was reading a lot about modern physics. I was reading a lot about this metaphysics and trying to sort of like, and that obviously sort of like has direct path towards philosophical questions. So I started engaging with some of those. At the same time, I think in O levels, I think I started engaging with some of the broader questions about religion and philosophy of religion, and I was reading a lot about that. And I think that was another path that led me towards sort of like philosophy. So I think I think I had a very sort of like curious and critical mindset in that I think acquiring a lot of information, reading a lot of different perspectives, and I was trying to actively make sense of that and questioning things. And as I was doing that, I was sort of like learning that there are all these people throughout history who have asked similar sorts of questions, who have engaged with them, and who have tried to provide very thoughtful answers. So I started reading about that. And I think one of the philosophers who had a huge influence on me during my teenage years was Bertrand Russell. And I think these days, I think, you have a lot of resources over the internet. Sort of like, I think, you can order different sorts of books, there's a lot more options now. Back in the day, I had very limited resources, but through sort of like, through some miracle, like one of the philosophers whose books were relatively accessible was Bertrand Russell. So I read a lot of Bertrand Russell during my FSC years. I read his history of philosophy. I read his works on sort of like in his work in skepticism, his essays, and I think that was sort of like very very transformative for me. And as I was sort of like reading about philosophy, when we start getting into philosophy in the 20th century, you see that philosophy in the 20th century starts engaging with a lot of different sorts of scientific disciplines, and one of which is psychology. And you see this engagement of what does psychology tell us about human nature? what is sort of like, what sort of information does it reveal? And Freud, he was a neurologist, but he sort of like provided the foundation for psychoanalysis and influenced psychiatry in a great way. But his works, had a tremendous influence on philosophers subsequently as well. So sort of like, so examining sort of like, getting exposed to Freud's ideas and kind of like looking at how the impact that they had on philosophy, that kind of like solidified this overlap between philosophy, psychology, psychiatry. And I didn't know at that time, but over the last 20 years, philosophy of psychiatry actually has emerged as a very independent and robust discipline. It's sort of like, there are philosophers who specialize in this area. There's journals devoted to this. There are associations devoted to this. So this has emerged as a quite distinct academic interdisciplinary field where people are specializing in philosophy of psychiatry. I didn't know that at the time, but I sort of like, I somehow intuitively recognized that there's this overlap that exists between psychology, psychiatry, and philosophy. And I found myself drawn to that. And I think, I didn't set out to be interested in that, but I think I was just following my interest and curiosity as it developed.
Right. So it won't be wrong to say that it was constant reading that did not let your curiosity die. We'll definitely get back to philosophy and its relationship with psychiatry, but let's move ahead. So you decided to pursue your training from the United States. Why did you choose US?
Yeah, I think there was I think around the time, so when I was in my fourth year and fifth year of KE, I think this was a question that was on almost every person's mind, sort of like, do I want to stay in Pakistan, or do I want to go somewhere else? And I think there were a lot of issues that were driving that. One is that this was at that time, the salaries of people in house job and in their postgraduate training were extremely low. Like, this was before, I don't know if you remember or not, sort of like a long time ago, there were like many strikes, and there was this sort of like large upheaval when sort of like there was this mass strike of doctors all across Pakistan, especially in Punjab. And so that happened, after I graduated from KE. So I think there was substantial increase in salaries after those protests happened. So before that, the salaries were, quite low. They were sort of like, almost ridiculously low. And then there was sort of like this burgeoning crisis where you had very few positions for postgraduate training. So you had a lot of people who were graduating, med school, but you had very few postgraduate training. So there was sort of like this, this extreme bottleneck where people were just kind of like struggling to get a postgraduate training spot, and many were forced even to kind of like take up training on a voluntary, non-paid basis. And that obviously sort of like is a serious problem, that means that you're spending years of your life like not earning any meaningful income. And then sort of like the quality of that training was also in general quite suspect. So I realized that I think if I wanted a more stable financial future, and particularly for psychiatry, that if I wanted a training in psychiatry that was sort of like that prepared me well as a clinician, and that also prepared me well academically, that I would have to look outside Pakistan. I kind of initially thought about Australia for a little bit, but in those days, Australia was still pretty open, and there were a lot of people who went towards Australia, but things were beginning to change and things were beginning to close down a little bit. So US seemed to be the best bet. So I focused my attention on that. We didn't have a lot of guidance regarding electives at that time. So I think I missed out on a sort of like crucial window of doing electives in the US while I was in med school. I was sort of like afterwards, after I had graduated, I was able to do sort of like a pretty good observership at Baylor College of Medicine, which I think provided a very good sort of like foundation for me. But during my med school, at that time, sort of like, and again, limited guidance, not a lot of information available. I wasn't able to do much, but I did sort of like start looking into preparation for USMLE and start thinking of that. I did have some bad luck with regards to US visa. The first time I applied to the US so that I could go there, give my CS and do an observership, the visa was rejected at that time, sort of like, for unclear reasons. And when I applied again later, the visa went into administrative clearance. And, as you probably know, like administrative clearance is this limbo where, you have no idea how long it's going to take. So I was kind of like stuck in this sort of like weird situation where I'm trying to go to US. I've sort of like, I've given step 1, step 2, and I performed well on that. But I'm sort of like, I'm dealing with these visa obstacles. And so while I think that was going on, an opportunity emerged in Doha, Qatar. So they have a Hamad Medical Center there, and they accept, at least I don't know now, but they used to accept step scores as part of their acceptance criteria. So I interviewed for a psychiatry residency spot there, and I was accepted. So I started my psychiatry residency in Doha. I did almost a year there. In the meantime, sort of like, my visa issues got resolved. I was able to get sort of like my CS, step 3, and observership things taken care of. And so I was able to, so while I was a resident in Doha, Qatar, I was going through the match season. I was sort of like, I traveled to the US during my vacation to give interviews, etc. And once I matched, I left. But that was also, so even though it was kind of a detour and it cost me precious time in some ways, it was also a useful cultural experience, because psychiatry and sort of like the social dynamics are quite different in Pakistan, quite different in Qatar, and quite different in the US. And in having that sort of like international cross-cultural perspective, I think also broadened my horizons and provided me with a lot more appreciation of sort of like how society and culture influences psychiatry.
Right. So this leads me to the question that laid the foundation of KemPsych. Having had the opportunity of working in so many different cultures, how did you find the psychiatry in Pakistan different from that in the US and in the Middle East?
Yeah, I think that there are a lot of differences, and I think it's quite. I think first, I think psychiatry in Pakistan is fairly, at least it was. I mean, I haven't been in Pakistan in many years, so I can't speak much to how things are now. But back in the day, it was fairly disorganized. You have very few psychiatrists. You had very few sort of like hospital resources, and also sort of like, in terms of services, in terms of psychotherapy that is available, in terms of availability of medications, things like that. It was quite, things weren't ideal. Another sort of like thing was that, in general, I think my perception is that people in Pakistan are not that psychologically minded, and I think this is for a variety of reasons. But there's less of an openness to psychotherapy. That there's less of an openness to treat your distress, to treat your depression, anxiety as meaningful things that we need to work through, that we need to analyze and sort of like figure out. And so I think there was a lot of reliance on the use of medications. And again, sort of like another thing is that, at least back in the day, prescriptions sort of were very poorly regulated. So like anyone could go to any pharmacy and, pretty much get any medications. So there was very rampant use of medications such as benzodiazepines, where people were just sort of like, they weren't even going to the doctor. They would just like go to the pharmacy and, they would get sedatives and other things. And so there was a lot of self-medication going on as well. And I think oftentimes when people came to a psychiatrist, for years they had already been sort of like, using benzodiazepines or other medications on their own. So there was a lot of self-experimentation, which, quite kind of like, posed its own distinct kind of hurdles. And then I think, in general, because I think especially, for example, in hospitals like Mayo, where physicians are seeing very large volume of patients in a very small amount of time. So you don't sort of like see the sort of comprehensive diagnostic evaluations that you see, for example, in the US. So, for, like psychiatrists would, maybe talk to someone for 5 minutes, 10 minutes, and just sort of like enough to get a quick idea about what sort of like, roughly the diagnosis might be. And then you sort of like, you prescribe them something, and then the next time they come for follow-up, they might see a completely different psychiatrist who might have a completely different idea of what's going on. So there was a lot of like discontinuity in care as well. There was a lot of like reliance on this sort of like spot diagnosis rather than something more comprehensive. There was sort of like this haphazard psychopharmacology in which sort of like patients are trying their own medications in addition to what is being prescribed. And there's this general reluctance towards engaging in meaningful psychotherapy in terms of engaging with one's emotions. So I think in terms of, there are a lot of like, I think structural and social barriers towards that in Pakistan. Qatar was, I think, in some respects similar. I think, but I think they have more resources, and I think there was more time. I think in general the availability of medications. I think the amount of time available for sort of like diagnostic assessments. I think that was different. One thing that particularly struck me, and that I still remember about Qatar, is that they have this very weird social organization where the local Qataris themselves are sort of like in relative minority. I think they're like the 40% of the population. The rest is sort of like people from outside, and a lot of these are individuals from sort of like poor individuals from some South Asian countries like India, Pakistan, Nepal, who go to Qatar to work as laborers under very sort of like miserable conditions, very harsh conditions. So, and they're almost like a slave class. They're almost treated as sort of like as slaves. And then you sort of like have this middle class where you have doctors and engineers from Pakistan and in India who have sort of like who are in Doha. And they're working, and they're sort of like you can say sort of like running these fields for them. And then you at the top, you have the local Qataris themselves who are sort of like, who are wealthy, who own all the resources, who kind of like, make all the official structural decisions. And then you have a small number of individuals from various Western countries who are there as investors and who are sort of like, providing the money and other kind of things. And I think, especially in the labor class who were working in very harsh conditions, I sort of like saw very sort of like, quite memorable presentations of sort of like reactive psychosis, sort of like experiencing stress to such a degree that you become psychotic, like that sort of those sorts of presentations, severe adjustment disorders, or otherwise generally the intersection of severe mental illness and other living in extremely impoverished and distressing conditions, and sort of like and navigating that, I think was quite interesting. The US, I think, it's different I think there are a lot more resources, things are quite formalized. I sort of like, I think there are standards of care. There are very clear-cut laws regarding what you're expected to do, what you're supposed to do, what you can't do. There are sort of like professional guidelines. You get a lot more training. You sort of like, there's much more psychotherapy available. People in general are more open to psychotherapy and things like that. You have a lot more teachers available from multiple different backgrounds. There's a lot more research going on, a lot more academic activity going on. So I think sort of like US provided, I think, a very interesting contrast. And I think overall, I quite enjoy. I think I benefited a lot from my training here.
Right. So you talked about psychiatry being disorganized in Pakistan back then. It pretty much still is. And it does not only have a bad reputation among the general public, but also amongst the medical community and the doctors community. Why do you think is that so? And what can be done at our level to clear these misconceptions and reduce the stigma?
I think there are different sources of this. I think there's a I think there's been a very strong historical and social sort of like you can say sort of like misunderstanding and stigma surrounding mental illness that goes back sort of like, centuries. And sort of like, psychosis and experiences like that, um, they're still shrouded in sort of like mystery. Like, I think your average person, they don't quite know what to make of someone who is psychotic or someone who is like really depressed. So they struggle to sort of like, make sense of those severe psychiatric presentations. And so they approach them with suspicion, they approach them with fear, and sometimes a lot of the times they approach them with a sort of either like moralistic or supernatural understanding. So they might think sort of like, especially as you go out into the villages, that, oh, this person is sort of like, either, sort of like, some kind of jinn, or sort of like, other, or sort of like afflicted by like, by the devil, or sort of like other sorts like supernatural explanations of like, why this person this is. And then they would sort of like go towards religious healers or other sorts of like, religious sorts of interventions as a way of addressing them. Or they might sort of like think that, oh, this person is just, they're faking it, or they're sort of like, they're just being lazy, or they're just not being, a responsible person. And what they just need to do is that they just need to man up, and they need to like, get through it. Which obviously we know that for severe psychiatric conditions, like, that doesn't work. Or there's sort of like other sorts of like, especially regarding sort of like, women who experience psychiatric problems, they're sort of like, oh, they just need more responsibility, or yeah, ki shaadi kar do, or yeah, even sort of like for men, ki shaadi kar do, theek ho jayenge. That sort of odd, sort of like moralistic, social kind of thinking was quite predominant. So there was this sort of like, there was this uh, sort of like uneasy relationship with psychosis and madness and severe psychiatric presentations that was shrouded with moralistic tones and supernatural tones. And then within the medical profession, who should have known better, psychiatry was, there were very little education directed towards psychiatry, very few resources directed towards psychiatry. Like, psychiatry was treated almost as an afterthought. Okay, sort of like, oh, so like, maybe यहाँ पे 2 हफ्ते थोड़े से पढ़ा दिए, या 3 हफ्ते यहाँ पे पढ़ा दिया, versus like no mention at all of psychiatric things, within the medical education context. And so I think, so social stigma to hai, sort of like, outside the medical profession, you have
I think we have lost Sir. Let me just get back to him.
I think they were or something. Can you hear me?
It's all right. Yes, sir, we can. Please go ahead.
Okay. All right. So I was talking, so there's this sort of like stigma in the society, but then there was also this tremendous neglect of psychiatry within the medical profession. And once you sort of like neglect something, once you cast it aside, and sort of like, there was still this sort of like tradition of psychiatric hospitals like being like standalone asylums, that you're not even having a meaningful contact with sort of like, with psychiatric practice, the sort of work that is going on. So once you isolate something, once you sort of like, place it in sort of like, some container elsewhere, then you're just perpetuating those larger stigmas that exist within society, because you're not having any meaningful engagement. So you're still carrying on with this, even though you're a physician, even though you're medically trained, you're still carrying on with the same sorts of stereotypes and the same sort of stigma. And then I think, people had all sorts of, I think, mistaken views. I think there was this sort of like idea that, oh, if you become a psychiatrist, then you're putting your own mental health at risk, that you're sort of like, you're going to become a psychiatric patient yourself, that there's sort of like this sort of like demeaning caricature of sort of like, people who go into psychiatry. Sort of like this idea that, oh, you want to go into psychiatry, like do it at your own peril, sort of like, do it at the risk of your own sanity, that you're gonna get, infected. So I think, I think a big reason for the continuation of this stigma is that psychiatry has not been incorporated formally into medical practice, into psychiatric education. And I think the more you isolate it, the more you neglect it, the more misunderstanding there is, the more confusion there is, and more all of the cultural stigma, sort of like, continues on.
Absolutely, absolutely. I agree with you. Talking of stigma, let's talk about conversations in critical psychiatry, your interview series for Psychiatric Times. Please take us through that journey. How did that happen, and how has it been so far? And for those of our members who don't know what exactly critical psychiatry is, please give just a brief introduction of what critical psychiatry is and how is it different from anti-psychiatry. People usually confuse critical psychiatry and anti-psychiatry.
Yeah. So I started so there are sort of two sort of like fields here. So one, there's sort of like philosophy of psychiatry, which has been going on for several decades. It's a relatively more academic sort of discipline where you have a variety of different professionals from different backgrounds, philosophers, psychologists, psychiatrists, who have been asking various sorts of conceptual questions about psychiatry, sort of like asking things like what is mental disorder, sort of like how do we define this category, sort of like how do we determine its boundaries, what are sort of like the ways we understand it, sort of like how do we approach the nature of causal explanation in psychiatry, what sort of philosophical assumptions we are making when we talk about talk about mental illness. How do we understand the relationship between mind and body when it comes to mental illness and psychiatric disorder? So there was sort of like this all these people who were asking these philosophical questions, and that was sort of like largely went by in the name of philosophy of psychiatry. There was also a sort of sister movement that had been going on, and it sort of like it kind of loosely, broadly acquired the name of critical psychiatry. And what they were doing was that they were focusing a lot more on issues of practical concern. So they were looking at sort of like the ways in which diagnoses operate in society, sort of like the ways in which like what happens when individuals are diagnosed as being mentally ill, sort of like how do those individuals react themselves, how does the society react, if the boundaries between what is mental and what is normal and what is disordered are fluid and blurry, then sort of like how do we approach this issue of over medicalization, sort of like how do we understand that, sort of like and sort of like also talking about sort of like practical issues such as the risks and benefits of psychiatric medications, sort of like because historically the side effects of a lot of these medications have been downplayed and sort of like their effects kind of like ignored, minimized. So critical psychiatry was sort of like looking at all of these things, and there was also an emerging service user movement in which people who were recipients of psychiatric care, who had experienced involuntary hospitalization, like who had been admitted to the hospital against their will, who had been administered medications against their will, they were now sort of like becoming more politically conscious, and they were kind of like raising their voices, and they were talking about their own unfavorable experiences with psychiatry, their experiences of coercion, their experiences of being dismissed, being labeled, being stigmatized. So they were sort of like this emerging movement where there was a lot of consciousness and a lot of discussion surrounding the social sort of like dynamics of diagnosis, of treatment, the harms of sort of like human rights and coercion, and how do we deal with that? And sort of like that was kind of like broadly going by within this label of critical psychiatry. It has overlaps with the traditional anti-psychiatry movement as well. And I think this is because the traditional anti-psychiatry movement, it was also not, it wasn't a homogenous movement. It wasn't like, so like there were like a few group of people who all believed the same thing. It had very diverse strands. A lot of what we think about anti-psychiatry emerged as academic critiques of various sorts of psychiatrists and philosophers. So there was Thomas Szasz in the US who wrote the book, The Myth of Mental Illness. And that was essentially a philosophical critique of the notion of mental illness. I mean, it was problematic in many ways, but it was essentially working within a philosophical sphere. Then you had the philosopher Michel Foucault, who was talking about how psychiatric power operates, the sort of power that institutions wield, and sort of like the historical and social factors that influence institutions like that. And then sort of like you had R.D. Laing in the UK, who was examining psychosis from a very existential standpoint. So you had these sort of like, very sort of like bright, intelligent philosophers and thinkers who were making these academic critiques and challenging psychiatry in a very sort of like very prominent fashion, you can say. But these were essentially academicians, sort of like, these are philosophers. And sort of like, and then there's that other side of anti-psychiatry, which I think a lot of people think about now, is sort of like these are groups like the Scientology movement, who oppose psychiatry for a variety of sort of like reasons that are based on misinformation. So Scientology, for example, has a religious opposition to psychiatry, and these sorts of groups rely on propaganda and misinformation in the same sort of way that anti-vaccine community relies on misinformation and propaganda to campaign to vaccines. So I think when we talk about anti-psychiatry, we have to sort of like clarify a little bit what part of what sort of things are we talking about, because these are quite different. I mean, there are links here and there, but so critical psychiatry in general is sort of an offshoot of the intellectual academic branch of anti-psychiatry, you can say, is that it was influenced by the sorts of critiques that Michel Foucault, Thomas Szasz, and R.D. Laing were making, and they incorporated and sort of like they tried to sort of like incorporate a lot of those arguments in their own analysis of psychiatry. A big difference is that in general, critical psychiatry does not seek to abolish psychiatry. So it doesn't say that, oh, we have to like get rid of psychiatry or psychiatry shouldn't exist. What it's doing is that it's sort of like it has a more reformist flavor to it. Is that it thinks that there are all these different sorts of problems with how we understand psychiatry, how we practice that, and we need to analyze that, and we need to sort of like reform it. So that's kind of like, one way you can, obviously these are overlapping, but one way in which you can sort of like distinguish between critical psychiatry and psychiatry. There are also a lot of links between critical psychiatry and philosophy of psychiatry. And I was very interested in both of these topics. And I think as I was finishing up my training, when I was a fellow at UCSD, University of California, San Diego, I started sort of like thinking about like, what can I do that I can better inform and educate general psychiatrists about these sorts of debates and about these sorts of discussions that are happening, because I felt that it was very important that these discussions take place in a manner that is accessible to psychiatrists, psychiatry trainees, and also other individuals in psychiatry. It so happened that the former chairman, chairman task for DSM-4 is the psychiatrist named Alan Francis. So he's a very prominent psychiatrist. He led the project for the development of DSM-4. And interestingly, when DSM-5 was being developed and when DSM-5 was coming out, Alan Francis became a big critic of DSM and sort of like and over medicalization and over treatment. So he was this inside player who had been part of the psychiatric establishment, but now emerged as one of its fiercest critics. And so he had actually he was now retired, and he lived in San Diego as well. So I reached out to him, and we happened to sort of like meet, and he was very supportive of sort of like of my interest in what I was doing. And so we ended up sort of like, I started the series with him, in that I started he was the first person I interviewed for that. And I sort of like, engaged with him and sort of like, asked him sort of like about his own views and the development development and various sorts of philosophical and critical questions that had happened. And so, that interview was pretty like well received by, I think it was published in Psychiatric Times. The editorial team really loved it. It was received very well by people who read it. And so that provided a means for me to show, to continue this task forward and interview other people who had been doing philosophical and critical work, and as well as related work in history of psychiatry and sociology of psychiatry. So far, this was started in early 2019. So this has been going on for more than 2 years now, and it has been received very well. It has a very large readership. There are almost, I think we're almost at about 28 interviews that have been done over these past 2 years, and some very prominent and notable individuals. And I think overall, I'm very pleased with the response and the reception of this series. And again, I think one of my goals was educational, so that medical students and trainees can access these debates and access this literature. And I think that I like to think that these interviews provide an accessible introduction for medical students and trainees as well, who are interested in these aspects of psychiatry but don't know where to start.
Wow, that sounds really very interesting. And to get to know more about philosophy of psychiatry, do tune into our talk, Philosophy of Psychiatry, on 26th of May, 8 p.m. Pakistan Standard Time. Sir, I would like to ask.
I'll just clarify that the talk next week is on history of psychiatry. So it does have some philosophical themes in it as well, but it is primarily about history, and it's basically kind of like giving a tour through major historical developments related to psychiatry. So that's the focus of the talk next week.
Right, we'll be eagerly looking forward to that. Sir, why do you think that psychiatry, if not being the only, it is one of the top fields of medicine that requires and receives so much criticism, be it positive criticism or negative, after all these years and all those developments?
I think there are a wide variety of reasons for that. I think, one, I think is that the subject matter itself is so difficult and so contentious, because I think what we are doing is that we are taking people and we are talking about their behavior. We are talking about their who they are as individuals, and we are we are labeling them, we're classifying them, we're trying to regulate them, and so anytime we deal with this domain of human behavior, human self, it becomes quite contentious, because different people are going to have different perspectives. They're going to have different understandings of those things, and so it's by nature the very fact that we're dealing with people's emotions, we're dealing with their behavior, their sense of self, is that there's going to be differing opinions, there are going to be reactions. And another thing is that when we're dealing with psychology, we inevitably run into a lot of hidden philosophical issues. How do we understand the relationship between mind and body? What exactly is the mind? And how is it that do we conceptualize these conditions as being bodily diseases the same way that we conceptualize them as being neurological diseases, or is this something else? And if this is something else, then what is the best way to understand that? How do these behavioral problems fit in within the realm of medicine? Why are we calling these problems medical problems to begin with? How is it that we can influence someone's behavior with the use of medications? And what does that entail? And what are the ethics of doing that? So what are the things we need to be mindful of if we are going to try to control someone's behavior with the use of these medications? And once we get into that realm, there's that social oppression aspect of it, where we can use the language of science to oppress other groups and oppress minority groups in the society. So the classic example in the history of psychiatry has been that of homosexuality, where homosexuality was diagnosed as a mental illness. It was treated as a mental illness until the 70s, when it was declassified by American Psychiatric Association. So that's a very clear example of the discipline using its power to regulate something, that in retrospect is unethical. But there are a lot of other sort of like issues as well. So, for example, in Russia, like psychiatry was used as a mean of political oppression. So it's like, political dissidents were diagnosed with schizophrenia and put in psychiatric hospitals. And even right now, you're seeing all of these debates surrounding autism and transgender identity. Is that sort of like, the very fact that we are classifying people comes with a lot of responsibility. Is that, are we doing it the right way? Are we doing it ethically? And what is our responsibility to these people that we are diagnosing and labeling and treating, sometimes against their will? And the very fact that we are treating people against their wills on some occasions, that obviously has to happen within an ethical framework. So what is the ethics that governs this practice? What is the ethical justification for that? What are the limits of psychiatric power? And how should we understand that? So I think there are some very good philosophical and social reasons that are embedded in the nature of what we do that makes it contentious. So I don't think this controversy is going to go anywhere. And I think it's very important for us to engage with it rather than dismiss it. Because if we dismiss it, we're just going to repeat the errors of the past, and we're going to continue on the oppressive practices that have been going on.
Absolutely, absolutely. I agree with you. And as they say that if you are not being criticized, this means that you are not doing something influential. So we'll take it as positive criticism, and we hope that it helps psychiatry grow as a specialty. So we are already running short on time. We took permission of an hour. So if you can just give us 10 more minutes, we have some questions from the participants. If you allow us, I'd like to take them.
Yes. I can stay for long. Yes.
Thank you, sir. Abu Bakr is asking that as the years have passed on, now when you are trying to integrate philosophy, psychology, and psychiatry, have you actually found an answer to some problems or questions you had in mind for a long time? Or does it become more and more a labyrinth as you have delved into it, thus rendering all your struggle to find some answers not much worth of time till now?
I think that's a very good question, and I think that also often comes up within the context of philosophical inquiry. Is that sort of like, are we making progress? Is this going to result in something, or are we just sort of like going to be asking questions? I think there has been progress. I think that all the philosophy of psychiatry and critical psychiatry discussions that have happened over the past decades. I think we are in a more sort of like intellectually and philosophically informed place now than we were decades ago. And I think there are several reasons for that. One is that I think philosophy is really good at identifying and eliminating bad explanations. So, so first thing sort of like we do is that we're able to identify all the different sorts of answers that are being proposed by scientists, by various individuals in society. We can sort of like, identify, like these explanations don't make a lot of sense. These are problematic. This is something that we have to sort of like examine, scrutinize, look into. So the first sort of like that part is identifying bad explanations is something that philosophy has done really well. Then the second part is that clarifying those concepts in a much sort of like better way and trying to suggest answers. And I think we have made a lot of progress over that in the last couple of years as well. And I think if you look at the philosophy of psychiatry literature, I think sort of like, there's much more clarity about what these concepts are, what they refer to. And there's also sort of like, much more clarity on what sorts of directions we need to take, or what sorts of answers can we expect for questions. So without sort of like going into the details of sort of like what those philosophy is or not, and this is something we can talk about in another session. I think that we can do more exclusive for philosophy. But the sort of like simple short answer is that yes, at the end of after you have sort of like engaged with philosophy of psychiatry, there is progress and there are meaningful answers out there. You're not going to get 100% certainty because that certainty never exists, not even in the sciences. But you do have meaningful answers, and you do have more conceptual clarity.
Right. Salman Aswar asks, do psychiatrists earn any less than other physicians?
Can you repeat that, please?
Do psychiatrists earn any less than other physicians?
Okay, so well, in the U.S., if you compare them to the surgical specialties and the interventional specialties, they earn less. So, for example, if you compare psychiatrists to general surgery or any of the surgical specialties, or if you compare them to medical subspecializations, so for example, if you compare them to cardiology or gastroenterology, they're going to earn less. But that's just because those are high earning specialties. If you compare them to internal medicine, if you compare them to family medicine, if you compare them to neurology, they actually earn in the same range. In general, the pay of psychiatry tends to be better than family medicine and tends to be pretty comparable to internal medicine. So, so overall, it's not that is substantially lower than other medical specialties. In fact, it's better than many specialties. I think pediatrics, I think primary care, family medicine. I think if I remember correctly, I think they are slightly lower than psychiatry in terms of their averages. So psychiatry is still sort of like compared to all the specialties, still kind of like near the bottom, but it's not at the absolute bottom. It's I think it's comparable to or doing better than a lot of the general medicine specialties.
Right. Sir, do you yourself do any positive or negative criticism regarding the whole Institute of Psychiatry as it stands now?
Yes, yeah, I have been sort of like part of the sort of like the scholarly work that I've been doing over the last 2 to 3 years is that I've been engaged in various sorts of philosophical and critical analysis, and I'm happy to sort of like share some of that sort of like literature as well, some of the publications and articles that I've had that look into that. But I think sort of like in general, the areas where I have sort of like devoted my attention to are the areas of sort of like the definition of mental disorder. Like how do we approach that issue of definition? How do we approach the issue of determining the boundary between what is disorder and what is normal, or what is disorder and what is simply social deviance? So this boundary question of where disorder ends and where either social deviance begins or where so-called normality begins. So that's been of great interest to me. The other area where I've been sort of like very interested in is the area of classification. Is that how should we best philosophically understand psychiatric classification? What should be our goals? How should we better inform that? What are the problems with existing classifications, particularly the DSM classification? So examining the limitations and the shortcomings of DSM classifications, and examining some of the alternatives and proposing sort of like philosophical solutions for that. So those are the two areas where I personally have been very interested in, where I have done some more work.
Right. In context of medical students who shouldn't join psychiatry?
I wouldn't say, I don't think there's any sort of like blanket contraindication by itself. I think sort of like I think any capable medical student, I think sort of like can join it. The only thing I would say is that I think you should go into psychiatry because this is something you like, this is something you're passionate about. I would sort of like I would say sort of like don't go into it for sort of like for bad reasons, like bad reason being that if you think that psychiatry is not hard work, so you're looking for an easy way out, and you think that, oh, psychiatrists, they're just kind of like, they don't do that much, they're just lazy, or they're just a few medications in psych, so I'm gonna go in that psychiatry because I want to avoid the hard work of other specialties. But I think that's a bad reason of going into psychiatry, and if you go into psychiatry with that mindset, you're going to be a bad psychiatrist, unfortunately. So I don't think there's any contraindication. I think if you're interested, if you're passionate about psychiatry, you should go into that. There are, I mean, obviously, the nature of what we do is that there's a lot of talking involved. Like you have to spend a lot of, there detailed history taking, detailed clinical interactions, and you're going to see a lot of disturbed presentations. Like people who are extremely disorganized, sometimes people who can be agitated, people who are at sort of like really bad depression, people who are experiencing crisis of various sorts, sort of like suicidal crisis, things like that. So that's just sort of like the nature of what we do. So, you need to have some familiarity with that and some sense that you're going to be able to tolerate that. Is that, if you can't tolerate emotional distress, that would be like one reason to consider not going into psychiatry. But sort of like, but in general, there's a lot of distress in medicine anyway. Sort of like, even in medicine and surgery, you see people in acute pain, you see people suffering. So it's not like there's not suffering in other specialties. It's just that the nature of suffering is more psychological. So you just need to be prepared that if you want to go into psychiatry, that you're going to involve, it's going to involve a lot of talking, and it's going to involve a lot of like sitting with emotional suffering.
Absolutely. One last question. In Pakistan, psychologists and psychiatrists appear at odds with each other. For instance, psychologists have been known to dismiss a psychiatric clinical diagnosis, while psychiatrists dismiss their role in healing illness in favor of medications. How should doctors go about bridging this gap?
Yeah, I think sort of like the relationship between psychiatry and psychology is a pretty interesting one, and I think it's kind of evolved differently in different countries depending on the healthcare systems. So for example, in the US, there is relatively less of a direct competition between psychiatry and psychology. In general, there's a pretty good collaborative relationship, and people sort of like, they work together. You see less of that animosity and less of that hostility. Because I think this is also because sort of like, I think the US is a very capitalist sort of, sort of like environment, and it's not like there's a limited sort of like pie, and sort of like people are sort of like, fighting with each other to sort of like, get a share of their resources. If you're a psychologist, you can open your private practice, you can directly see patients if you like. So you see less of you see less of a conflict. For example, in the UK, there's a lot more I think conflict, and I think this is because it's sort of like more socialized medicine. I think you have less resources, and I think there's competition within the system between psychologists and psychiatrists regarding who gets to be in power, and then who gets to have sort of like, more resources and gets to have control of the situation. I think Pakistan, I think situation's a little bit more, there isn't a central control. I think people are kind of like, largely operating kind of like on their own. And I think this is kind of bad in its own way, because you're not seeing a lot of like collaboration. And if the psychologist is kind of like doing their own thing completely, and they're approaching diagnosis in their own way, and they're approaching treatment in their own way, then there are going to be situations where they're going to be at odds with what the psychiatrist is thinking and what the psychiatrist is recommending. And this is bad for the patients, because if a patient is hearing one thing from the psychiatrist and a different thing from the psychologist, then like, what do you do? How do you navigate that? I think this sort of collaboration has to begin with early during psychiatric training. Is that during psychiatric residency, for example, we need to be able to like work closely with psychology as a profession and understand like what they do, how they approach things, what are the methods they use, their perspectives. And psychologists need to work closely with psychiatrists and kind of like, understand their methods. Because there are going to be differences, because these are different disciplines, and there are, the goals of medications are different from the goals of psychotherapy. So, I believe they should be seen as complementary rather than something that are conflicting or mutually exclusive. And there's also, I think, there tends to be a bit of an ego problem. I think in a certain situation more than other, where I think both like, psychiatrists and psychologists, they can sort of like have this ego that where what I'm thinking or what I'm saying is the right thing, if that's the truth, and how dare someone else say something different. And I think when it comes to medicine, I think we have to rise above our egos. I think we have to kind of like think about what works best for this patient. For this person, are they going to benefit more from psychotherapy or medication? Are they going to benefit more from a combination? What do they want? How can we help them? And I think if we make the care more person-centered, I think we would naturally sort of like come to a point where we're working collaboratively because it's only with collaboration that we can come up with the best plan for the patient. But if we are thinking more egoistically, then I'm just going to stick to what my training tells me. I'm just going to stick to my diagnosis, and I'm going to stick to my medications, and those are the best way to treat everything. And I'm going to dismiss what others are saying. Then there's going to be conflict. Then there's going to be a problem, and that's not going to be a healthy environment for anybody.
Exactly. Thank you so much, sir, for your time. We have one perfect question to wind up this talk from Salman. He asks, for a beginner like us who is interested in psychiatry, can you please suggest one or two books that make us more enthusiastic about the field?
Yes, yeah, I think there are several books that are out there. I think for me personally, I think reading about some of the psychotherapy stuff was hugely sort of like, influential for me in kind of like, developing my own thinking about psychiatry. So there's so one person that I read during my med school that I would also sort of like recommend is Irvin Yalom. So Irvin Yalom was a psychiatrist and existentialist, sort of like philosopher and writer, and he wrote sort of like several books of fiction, but he also wrote several books sort of like detailing his case studies and producing sort of like narratives of the literary narratives of his psychological case studies. So there's this book called Love's Executioner. I can just actually type out the name in the chat bar as well. Love's Executioner by Irvin Yalom. That's I think something that's seen as a classic. It was written in the late 80s, I think 88 or 89, but it's still a very wonderful read. There's another book. It's called The Examined Life, and it's by a psychoanalyst, Stephen Gross. I think that's another good one. I'm going to sort of like paste that in the chat as well. So it's called The Examined Life by Stephen Gross. I think that sort of like presents quite interesting view of sort of like psychotherapy. If we're thinking about sort of like psychiatry, especially history of psychiatry, there's a book called Shrinks. It's written by one of the past presidents of the APA, Jeff Lieberman. Now there are a lot of like issues with that book as well. I think the narrative that comes from the story, I think it's kind of like the establishment version of what happened. Sort of like it's sort of like a glorified version of what the psychiatric leaders would like to think history of psychiatry was like. But I think as an introduction, I think for medical students, this can be a pretty useful book as a starting point to begin to understand how psychiatry has evolved over the years. So I've just pasted that as well. Shrinks by Jeff Lieberman. One book that I really like, but it's rather philosophical and sometimes technically philosophical. So I don't know how much sort of like how accessible it would be to an average medical student. But that book changed the way I think about psychiatry. It has a tremendous influence on me. It's called What is Mental Disorder by Derrick Bolton, and it was published in 2008 by Oxford University Press. Remarkable book on a philosophical analysis of psychiatry. If you're interested in reading something older, like one of the classic anti-psychiatry works is by R.D. Laing. It's called The Divided Self. It's an existential analysis of schizophrenia. I read that shortly before I started my residency training in the US, and I also thought it was quite. I mean, it's very interesting and thought-provoking, and something sort of like to look into. I'm trying to think of like other books. If you're interested in sort of like more conceptual stuff on related to psychiatry, I recently wrote an article for academic psychiatry. It's called Conceptual Competence in Psychiatric Education and Training. And in that article, there's a list of books and journal articles which I suggest as recommended reading as part of sort of like developing a better conceptual understanding of psychiatry. So I can forward that article to sort of like, maybe I can do it to Yusha. I have his email, and so and then you can forward it to other individuals who are sort of interested, or maybe it could be posted on the Facebook group as a PDF. And so that has a table which contains more recommended readings, especially regarding the conceptual and critical aspects.
Sure. Thank you so much, sir, for taking out time for us and giving the honor of hosting you. It was an absolute pleasure to have you. And we are eagerly looking forward to your next talk on 26th of May. Thank you so much for taking
Thank
out
you.
time for us.
Thank you. And I think one thing I'll do is I'm also putting my email address in the chat box. You know, I'm always very happy to hear from medical students, from trainees. You know, if you are interested, if you have questions, if you would like to explore more, like don't hesitate to email me. Don't hesitate to reach out. I'll try to guide you in whatever way I can.
Thank you so much, sir. That really means a lot. See you on 26th of May.
Okay. Thank you.
Thank you, sir. Goodbye.